Do we need to get set up as co-hosts?
Hello, hello.
And maybe you were early.
Yeah.
We're host and co-host.
Once we see that they're let in, I'll play it just for a minute and then I'll share our screen.
Sounds good.
Can you see that okay, Susan?
Yeah.
Okay, cool. I'm just gonna practice switching the music to my screen because with this new Zoom, I'm not sure if I can do it.
Sounds good.
Volume okay?
Oye,
That's good.
el sistema para que sepa.
I'm just gonna see if I can do both screen and sound. Oh, you know what though? It will be awkward because then the music keeps playing. So I'm not gonna do that. I'll just do the music first.
Just an FYI, Karissa, I see in the chat there are currently 7 people in attendance.
Oh, good. Okay. I'll just play the music then. Welcome to those that are joining us. We're going to get started in a few minutes. The section starts officially at 1:15, so we're going to play a little music while we wait.
Oye, Ori, el sistema para que sepa. Vamos. Rumbera, vente, vamos a bailar que suena.
Suena porque suena.
Música bien vacila, verbena. Oye, la que te empieza llega candela. Pa' mi gente rumbera, rumbera. Ay. Vente, vamos a bailar que suena. Vaciladito, guay. Música bien vacila, verbena. Ay, güey. La que te empieza llega candela. Pa' mi gente rumbera. Vamos pa' la verbena. Rumba, rumba, rumbera. Vamos pa' la verbena. Rumba, rumba, rumbera. Óyelo, yo, Bori. A mi gente sistema, papá. Vaciladito, guay. Vamos pa' la verbena. Rumba, rumba, rumbera. Vamos pa' la verbena. Rumba, rumba, rumbera. Vaciladito, pa.
Mueve así, este de aquí, entre en vacile. Tú te mueves así, este de aquí, entre en vacile. Tú te mueves así, este de aquí, entre en vacile. Tú te mueves así, este de aquí, entre en vacile. Este está que arde, vente pa' acá. Abrazarte lento es lo que va a pasar. Una combinación de cabeza y baldosa. Mirada que va a pasar. Lo echa pa' acá. Lo que va a pasar.
Ahí, güey. Vaciladito, guay. Vamos pa' la verbena. Rumba, rumba, rumbera. Vamos pa' la verbena. Rumba, rumba, rumbera.
entra en vaciles. Tú te mueves así, esto de aquí entra en vaciles. Tú te mueves así.
Welcome, everyone. We're excited to have you join us today. This is our session, Nothing for Us Without Us, and we'll go ahead and get started. Hopefully you enjoyed the music for anybody that was coming in a little bit early. We know the power of music at the Center for Wellbeing, and we love to share it with y'all. So this session is Nothing for Us Without Us. This really centers on the work of the Center for Wellbeing, where we did a community-based blood pressure campaign that empowered community health workers to elevate their voices for continued funding for health equity outreach. So really looking at kind of the need during the pandemic and then post-pandemic. So this session has about 5 sections. So we'll do a little introduction to the Center for Wellbeing. We'll give our history about community health worker health equity work. We'll talk about It's Up to Us, which was a community health worker blood pressure campaign. And then what we did during the pandemic, where we really aligned forces with other organizations centering on community health workers and Promotores de Salud. And then once that funded ending, we really looked at advocacy to uplift the voices of community health workers and have their leadership respected. But first, a little about us. Susan, I can't hear you. I don't know if anyone else can.
Can you hear me now?
Yes.
Perfect. Okay. So hello, everyone. My name is Susan Garcia. I'm the Community Health Worker Manager with the Center for Wellbeing. And I actually started with the center back in 2015 as a health promoter, a community health worker. And I was doing nutrition education out in the community. And since then, I've, grown in my role. I became a coordinator at one point, helping coordinate a lot of our different programs out in the community, from blood pressure screenings, as Karissa mentioned, to still coordinating even to this date some of our nutrition education work. And now as a CHW manager, I not only help with our different programs that we have in the community, but I also am a training facilitator for our community health worker trainings. I also facilitate a community health worker networking meeting here in our county, as well as help in overseeing our community health worker newsletter that we send out monthly, as well as advocating for our organization in support of community health worker efforts here locally as well. I'll pass it to Karissa.
Thanks, Susan. So I'm Karissa Moreno, the Executive Director of the Center for Wellbeing. This is us in our last year's Celebration of Dreams, which is an annual event where we really celebrate the work that we do in community. Fun fact, I started my health career as a community health worker and have really empowered community health workers throughout probably the last 2 decades. So worked first in South America as a community health worker, and then locally in Sonoma County as a perinatal community health worker. I worked for about 10 years in federally qualified health centers, where I really centered community health workers kind of in a broad top-of-scope workflow. So really trying to disrupt how it is that we had been doing healthcare in the primary care setting and empowering community health workers to be those key and essential liaisons. And the work at the Center for Wellbeing really continues to meld those passions, because a lot of the work that we do is about community health workers. So just a little background about the Center for Wellbeing. We have been in Sonoma County for 30 years. This is our 30th anniversary. And our mission really is to address health equity. And we recognize that health is not just the absence of disease. We were doing kind of diversity, equity, belonging, and inclusion way before it became a popular term. And we've really been looking at how do we bring voice and power to each individual in the community, really helping people have not just voice, but political, social, and economic viability in communities. We also recognize that health is complicated and there are many prerequisites of health. And this is something that we include in our community health worker training. So way back in 1986, the World Health Organization came together and they really looked at what are the foundations of health and well-being. And these are the 8 prerequisites that they came up with. So peace, shelter, education, food, stable ecosystem, sustainable resources, equity, and social justice. So really cool to see that they recognize that equity and social justice were really essential to our ability to be well. And these also really address some of the structural drivers of health or social determinants of health. So those external factors that can influence how well we can thrive or conversely not. So our strategy to address our mission is really through upstream community programs and then treatment or clinical services. So we have nutrition therapy. We serve about 1,500 unique individuals annually through this scope of work, really helping people have access to the tools and knowledge and support that they need to be well. We also have the only cardiac rehab in Sonoma County where we're really serving our aging population or those that are impacted by a cardiac event. And this is like the happiest place on earth. You go into our cardiac rehab, it's called HeartWorks, and people are just there and they're encouraging each other. It's really exciting to see this. We also recognize that improvements in our community really start with our youth. And so we're in about 60 schools in Sonoma County. We have physical activity programs. We have peer-to-peer teen programs where we're really helping build our leaders of tomorrow. And they do a lot of advocacy too, which is really exciting. We're also out in community providing education, connection to resources, and tools for folks to be well. We also recognize that it's not just programs and services that have an impact in our community, that we really have to address some of those systemic structural inequities. And so we're working really at kind of a policy level as well. And then, of course, our work around community health workers. So as Susan mentioned, we do everything from core competency training, we do special training, we have a monthly network meeting that provides resources and connection for community health workers. We do a lot to embed community health workers in all different sectors, so clinics and community and schools, and then of course a lot of health equity work. So our work has been published in many places. We're really excited about this. Again, we have been doing community health worker work for almost 3 decades, and the majority of our team are community health workers too. So we have a lot of expertise and, more importantly, passion and compassion around this work. So some of the trainings that we do, we are in the state of California. So we have a core competency that aligns with state recognition for this. We also do a lot of specialty training. So for community health workers that are serving our expecting and parenting people, really with a two-gen model of care for community health workers that have a restorative justice lens in schools, of course, the community-based blood pressure screens, and then many other specialty trainings. And then again, we have over 25 years in this. All of our curriculum is designed by community health workers, public health experts, registered dietitians. So we have a lot of expertise here. It's also rooted in up-to-date data. We really recognize that data and facts give us power, and then we bring that to a place of where do we have action in this. All of our trainings are strength-based and human-centered, and it's very hands-on and participatory. So we really respect and honor the lived experiences and voices of the participants. Currently, we deliver our trainings via Zoom, so this is accessible for anyone that wants to access it, and we train about 100 community health workers annually. So this is what our training looked like pre-pandemic. Our cohorts would have about a dozen folks. And then you can't see all the faces, but this is a very crowded Zoom room. This last year, we've done 2 cohorts of community health workers with almost 50 participants each. And you can see everyone's got their camera on, people are really engaged. And so we've found ways to really connect and create community, even though we're in our little Zoom boxes. So we still have fun. But we at the center do amazing work, and we're just really pleased and excited to be in space with you today and share a little bit about our learnings around community health workers. So to start us off, I just wanted to set the stage and talk a little bit about our background and how we came into the space of community health workers. So the Center for Wellbeing was born in 1994, really with the recognition that what was happening in the public health or primary care domain was not serving our community. We had a lot of health disparities, and there was a lot of siloing of our efforts. And so the center was started really to be that link between primary care and preventative services and work out in community. And really critical to this was the work of community health workers. So since the 90s, the center has been engaging, training, and empowering community health workers and Promotores de Salud to perform health education, primarily in underserved populations or communities. So we're really looking at where are those critical points where people are either not accessing information, or there's a lot of fear and trepidation in these communities, and really helping them gain access to the information and resources that they need. Importantly, all the community health workers that we work with are community members. And so really underscoring that definition of who a community health worker is. So that trusted messenger who is uniquely experienced or has a deep understanding of the community that they're serving. And so we intentionally recruited community leaders in the different neighborhoods and spaces that we were working in that were really passionate about helping their friends and their families and their neighbors. And so our methodology in partnership with these community health workers was place-based. So really going to where people are at, linguistically appropriate, making sure that we're bringing information, whether it's verbal or written or materials in the language that is appropriate for those communities served. Very human-centered, so not a one-size-all-fit approach. So really looking at what are the unique needs in those neighborhoods. And then always bringing it back to that place of strength. So what are the innate assets of the community members that we are serving? And then how do our community health workers really shine a light on that and uplift that? We do work inclusive of all ages. We've done a lot of work with our aging population, with our youth population, and everything in between. And then again, really looking at those marginalized communities. Wrong way. And then, kind of historically aligned with our mission to address health equities, we've looked at chronic disease prevention and management, nutrition, things like sugary beverages, exercise. So this was all kind of pre-2017. This is really where our work was centered really on these preventative services. So why is all of this important? We really know that community health workers are powerful, powerful advocates for health equity. They do so much work in so many different spaces. And so for us to really have a clear understanding of this, it's important to look at where we live. As we mentioned, we really center the work that we do in data, and we're really looking at where those gaps are and where the needs are. And this helps inform what it is that we're addressing. So the Center for Wellbeing, we're located in California, just north of the Golden Gate Bridge. So we're about 45 minutes or 60 minutes, depending on traffic. One thing that's important to note about California, especially since this is a national conference, is that there are a lot of needs in California. We're one of the wealthiest economies globally in California, but if you're looking at the California poverty measure, which is adjusting based on the high cost of living, California has the highest poverty rate in the nation, about 18 to 19% of the population. So this is something really important to note because we know that poverty is a key driver of health disparities. And so, as I mentioned, we're just north of San Francisco. We're in Sonoma County, which is a beautiful area. If you think of Sonoma County, it's kind of like Napa County. So lots of vineyards, agriculture, beautiful green spaces. But we also are suffering with the same type of health disparities because of that high cost of living. So there's a study that is done, it's called the Measure of America. And so this is really looking at something called the Human Development Index. And so on a 0 to 10 scale, it's looking at educational attainment, income ability, and then different factors that lead to our longevity or ability to have a long and healthy life. And in Sonoma County, our biggest town is Santa Rosa, where we're physically located. And in two neighborhoods that are only 5 minutes apart by driving, there is an almost 10-year gap in longevity. So in the predominantly Latina community in Roseland, that is just west of Bennett Valley, a predominantly white community, we see this huge disparity in how long people live. And so this is one of the things that really drives the work that we do, is recognizing where those disparities are and then what we can do about it, not just from a program level, but also through that structural level. And again, community health workers are really key drivers of change in these things. The high cost of living in Sonoma County is one of these drivers. The most recent data that we have is actually pre-pandemic, so from 1918, when the median income was about $87,000. Currently in 2024, the median income is about $99,000 for a family of four. But we can see the gap, and the gap kind of is about the same. So in 2018, a family of four needed to earn $110,000 to survive. And so if we saw the median income, there's a pretty big gap there. So this is one of those drivers. So housing costs is one of our most pressing issues in Sonoma County. About 13,000 families cannot access affordable housing. 65% of low-income households spend about 50% of their earning on housing. And if you're spending half of what you earn just on a roof over your head, you can see that there's a lot of gaps and other needs. And then in the past 5 years in Sonoma County, housing costs have increased by 40%. Sonoma County, as you might have heard, has also been impacted by climate change. So we've had year after year of floods and wildfires. Our biggest fire was the 2017 Tubbs fire, which consumed over 5,000 homes. And then in 2019, we had the Kincaid fire that forced the evacuation of 40% of our population. So these were really impactful for our communities. And if you can imagine, there's a lot of disparities, not only by income, but along race and ethnic lines as well. So we saw a disproportionate impact of these climate experiences on our BIPOC and Latina communities. Additionally, agricultural and tourism workers, which is one of our huge industries in Sonoma County, these workers were most impacted by the fires, and they were unable to tap governance support for a lot of reasons. And then, as I mentioned, Latina and BIPOC households were disproportionately impacted. Another thing that was really important to note during these evacuations and when services were being given, a lot of our immigrant communities were less likely to access resources or go to shelters. And again, this is why the work of community health workers is so critically important. We also have a changing demographic in Sonoma County. So the Latina community is growing. Currently, it's actually about 29% of the population, but this is continuing to grow. Currently, about 50% of new births in Sonoma County are Latina. And then 15% of our residents were born outside of the US, most of whom are undocumented. 40% have low English proficiency and 40% are uninsured, although this is changing with Medi-Cal expansion. And Medi-Cal is the Medicaid insurance in California. We also see gaps in educational attainment. So 35% have less than 8th grade education, and then 80% live in rentals. And it's about double the county rate. And what's important about living in rentals is that there's less stability there. So all of this is to say that we look at the data, we look at these disparities, and we know that community health workers are really critical to bridge these gaps. So the Center for Wellbeing is really centered in a lot of health equity work. We work in a coordinated way with a number of different collective impact initiatives. And we've worked and empowered a whole dozens of community health workers over the years, and we continue to engage them with different scopes of work. So we might have a scope of work, based on nutrition outreach, or we might have a scope based on blood pressure. So part of this collective impact work, California started the California Accountable Communities for Health, which led to Health Action in 2007. And then that was born to kind of a healthcare systems improvement in 2014. We were part of this work really from the beginning. And we recognize that in Sonoma County, cardiovascular disease and stroke was a major killer. And so we decided to start a blood pressure screening campaign, which was called It's Up to Us. And so I'm going to turn it to Susan to go over our next session, It's Up to Us, a community health worker blood pressure campaign.
Yes, so I'm going to be talking about our blood pressure campaign. This is one of the projects that started back in 2017 for us, and basically we got some data from our county that kind of indicated that heart disease and stroke were kind of the leading cause of death here in Sonoma County. And this was before the pandemic, so 2017. And we were also seeing that 1 in 4 deaths were due to cardiovascular disease, as well as 60% of our healthcare spending was being done on for diabetes and cardiovascular diseases. So it was very important to bring about a campaign in our community, because we knew that when it comes to heart disease, it is preventable. It's just a matter of providing the education and the tools and resources to be able to help lower that risk of developing heart disease. So with that, we launched our It's Up to Us campaign. And of course, our solution is to work with, next slide, Karissa, community health workers. So community health workers really became essential for this work. We knew that they are trusted messengers in our community that had been working with us for so many years already, delivering messages around nutrition education. And we knew that this could be something that could also be part of their scope, where they can not only be able to share this message, but also help folks feel empowered in the community to really take charge of their health and see what those numbers mean. With that, we went ahead and did our training and certification program. And our training and certification program, this is something that the center was able to design. We do have, as Karissa mentioned earlier, we do have our clinical nutrition services. So we have a team of registered dietitians that actually teach classes around diabetes, heart disease. And so we knew that they could help us in designing a curricula that was focused on specifically around heart disease, hypertension. So we were able to create 2 different curriculums. One was for an informal blood pressure screening, which I'll dive into in a little bit later, as well as a more formal 1-hour curricula that we were able to teach in classroom settings. So those were something that we developed, as well as part of the certification process. We worked with a medical provider that was able to do some of the was able to certify the community health workers that kind of sign them off that they are able to go ahead and conduct the blood pressure screening. So through these trainings, the community health workers learned about what is heart disease and hypertension. They also were able to learn how to take their own blood pressure and also how to take the blood pressure of someone else. And not only know what the blood pressure numbers mean, but also explaining the blood pressure numbers in simpler terms, so that way our community can really walk away with that knowledge and information of next time that they go to the doctor, you know, when they hear the blood pressure numbers, they'll really recognize, okay, I'm in a normal range, I'm in a high range. So really providing that information to them, as well as part of this also included doing some referral training, because we didn't want to just go and put this campaign out in the community and not provide some sort of resource for our community. So we were able to work with a lot of the local health centers in our area to really make sure that we had that partnership established, so that if a community health worker was out doing a presentation or out doing a tabling event and we encountered someone with high blood pressure, they would know the necessary steps to take to connect that person either back to their doctor, back to their health home, or to help them establish a health home. So that was also part of the training process. We went over everything. And as I mentioned, we kind of had those two different curriculums developed. So we had our presentation model, and this was something that, again, it was an hour lesson. And instead of having just like promoting, hey, we have a 1 hour lesson, folks can come sign up, we actually were very proactive, and our community health workers were able to help us identify some of the sites in the community where people were already gathering. So we went to family resource centers, we went to school meetings where parents were located, we went and sometimes offered them at apartment complexes. We were, you know, bring our table and our educational material to community rooms in the apartment complexes and invite the neighbors, everyone to join us. We also did job sites. We would go out to employer sites and really provide that information to the employees, as well as senior centers, which also became another area where we would just go into their community room and provide this information. And as you can see here in the display in the photo, we have community health workers that we would set up our table, we'd have our educational display, and that really had a bunch of images, but also the steps that folks could take to help lower the risk of hypertension. And then if you can kind of see, there's a blood pressure monitor as well on there. So everyone in the class would get a blood pressure monitor. And so we would go through the lesson of what is hypertension, what does heart disease mean, what does a healthy artery look like, what happens when an artery gets clogged. So we would go through all of that information, and then we would end by inviting one of the class participants to join us up front to get their blood pressure taken. And we'd go over what those numbers meant after we got their reading, and then we would encourage the rest of the folks in the class to take their blood pressure. So they would start by taking theirs, and then they would take that of their classroom mates. So it was in a way of like not only helping them feel empowered, but also empowered by knowing that skill set that they can take someone else's blood pressure. And we were also we also did tabling events. So we were at schools, churches, food distribution sites, grocery stores, farmers markets, health fairs. We were everywhere. And this was a quick 15-minute curricula that we developed. It's mainly as a guide for the community health workers. And we wanted this to be like, how do you bring someone to the table? How do you engage with them to come and sit down to get their blood pressure taken? But once you're there, getting their blood pressure taken, and then how does the explanation go through? Again, we know that health literacy is very important, and it's a key skill that community health workers have of breaking down complex topics such as hypertension into more understandable wording that can really help someone walk away and feel like, okay, I know what hyper means. It means high, and that means it's my blood pressure, so my heart's working harder to pump blood through to my body, to the different organs. So that was part of the process and even the certification. When community health workers were getting certified, they'd be taking the blood pressure of someone else and going through explaining that. And that's what the medical provider was signing off, that they were certified not only in taking an informal blood pressure, but that they were also able to explain everything in simpler terms. Next slide. And so I do want to kind of share kind of the biggest impacts that we saw through this campaign. So on the left, you see a woman that's getting her blood pressure taken. She's again pictured in the photo in the middle. She is between two of our community health workers, Xochitl and Ana. And this basically was someone that her name is Elena, and she is someone that we met in the community. Back in 2017, she had started to feel very weak and just tired. And she just didn't believe in going to the doctor. She felt like the doctor was just going to brush off her symptoms as, you know, maybe this is something due to age. But she went ahead, and one day she was she was going to the grocery store. Luckily, we had a tabling event that day. And Xochitl and Ana invited her to get her blood pressure taken. She had her blood pressure taken a few times, and she had multiple high readings. We come to find out that she probably needed to get connected to a health home. And that very next day, we were able to get her connected to one of the local health centers. So she was able to see a doctor, and she was prescribed medication, and it had an official diagnosis of hypertension. So that was really great to see that. What was even better was that a few months later, Xochitl, one of our promotoras, ran into her at a social gathering event. The Elena came up to her and said, "Thank you so much for having done that screening. It gave me all the answers that I needed. Turns out, yes, my hypertension was causing that fatigue because I feel so much better now." So it was incredible to be able to provide that through the informal blood pressure screenings and through that trust that was developed with the community health workers. And then on the right here, we also have Deborah, who is pictured in the middle, and we have Lucy pictured to the left, and on the right is her sister Esther. And this is also another great unique story that came out of this campaign. So Esther actually was a community health worker with the center, and she was coming in to do the trainings to be able to do blood pressure screenings in the community. But it was during this time where her sisters, Deborah and Lucy, were also coming into town. They're originally from Guatemala. And they were coming to basically just be here for a few months to get to be with family. And it was through these, Esther asked me, can they come to classes? Can they also receive the training? And we, of course, said, of course. This is a skill set that everyone can learn. So they came in, took the classes. And one of the things that we started to notice was that with Deborah, her blood pressure readings were super high. Every time we would have a training and we would practice doing the blood pressure, her blood pressure was high. We come to find out and learn a little bit more about her. It turned out that she was actually diagnosed with high blood pressure, an actual diagnosis of hypertension back in Guatemala. But because the medication costs were super high, she wasn't taking her medication. The medication was causing so many side effects. So it became very critical for her to, she just didn't know a lot of information about the medications. She didn't know a lot about the condition. And the other thing was she didn't know about the importance of doing blood pressure readings. And through all of this, we were able to get her connected to a doctor, so that way she was able to get some medication. While she was here, we also gave her a blood pressure monitor, and we are happy to report that after a few months, when she went back to Guatemala, she took her blood pressure monitor, and she's been managing her blood pressure. She's been feeling a lot better. And on top of that, she has been helping her neighbors and family friends get their blood pressure taken again. So this is kind of just the amazing work that this campaign brought out, is just helping people feel empowered with that knowledge and that skill set to really help not only themselves, but other folks around them that are important, right? Next slide. So just to kind of recap, so we, between 2017 to 2019, when we initiated this campaign, we reached 1,767 people, and that was screening them for their blood pressure. And out of that, we had 45% people that were had high blood pressure. And so one of the key things was with those people that we identified that had high blood pressure. A lot of the times we were asking them, do you have that diagnosis, and getting them connected back to their health home or helping them get established into a health home. So that was part of that. but then again, that increase in knowledge of like now knowing these different, what can we do, reducing our sodium intake, taking our medications, taking our blood pressure, doing that physical activity, all that knowledge gained was something that we saw many folks walking away with, as well as that sense of empowerment of feeling like someone was there cheering them on to really take care of their health. So this is kind of like part of the great piece that we were able to do with this program, was just being able to bring an important vital campaign into our community. Next slide. So we do amazing work, and we had such great success with this campaign, but this definitely led to more projects that were just as vital for our community. Next slide. And I'll pass it to Karissa.
And then COVID hit. So as soon as I say, we continue this work through 2019, and in 2020, our world turned upside down. So we're going to talk a little bit about what we did during the pandemic. So first, kind of looking at Sonoma County, the impact was really felt in our community. And as I mentioned before, we had a lot of disparities that ran along race and ethnic lines. So our Latina and our BIPOC community was definitely disproportionately impacted by COVID. So in 2020, COVID ranked as the 6th leading cause of deaths. We saw that in that first year, Native American deaths increased by 38%. Latina deaths increased by 31%. And then in 2020, the Latina community comprised 27% of our total population, but had 46% of the COVID cases. And one thing that we really tried to uplift in the early days of the pandemic was this was not our fault. This was really kind of systemic and structural things. A lot of our community members were agricultural workers or in the hospitality service or frontline workers. And so they couldn't take time off, or they lived in, kind of multi-generational houses, and they couldn't isolate if they became infected. They didn't have access to the testing. And so again, there was huge need once the pandemic hit. And then just, kind of correlated with this, we saw that deaths caused by drug overdose increased by 78% in 2020. So we saw a lot of mental health needs during this first year in the pandemic, a lot of isolation, a lot of confusion. So again, the work of the community health workers was really, really necessary during this time. So again, pandemic exacerbated inequities. From our former Sonoma County Health Officer, Dr. Sundari May, she said, the disparate impact of COVID-19 on our Latinx community is the result of long-standing health and social inequities. And so when we talked at the beginning of this session about those 8 prerequisites of health, again, equity and social justice are really critical to that. And I know we live in a world where some of those terms get politicized, but from our perspective, this is really about serving our humans so that everyone has what they need to be well. And so early in the pandemic, we continued to engage our team of community health workers. We looked at education on mitigation, connecting to resources like protective personal equipment, isolation strategies, financial assistance, linked to testing sites, and eventually vaccines. And you can see early in the pandemic, messaging wasn't so great. So like even our homemade signs to like get into the community. But again, really working at a place-based level. And we recognize that it was important to, again, bring education. So here we have Susan with Roseland CBI and Equidad, one of the group of promotores that have been long-standing in Santa Rosa and in Sonoma County. So again, just mobilizing these individuals that are so deeply connected and passionate about uplifting the needs of their community and being able to bring resources and education to them. So these are just a couple pictures of the early days in the pandemic. And it was just great to see that there was so much drive and desire to be in community and to support our community members. But we recognize that we are stronger together, and there was really a need to coordinate our efforts. We're a number of different nonprofits, groups of promotores that were mobilized during this time. There was different funding sources, but we thought, what can we do together? And so over here on the right-hand corner, where you see this medical provider, this is Dr. Jenny Fish. She is a huge community advocate. She's very passionate about supporting, uplifting the community health workers. And so she mobilized spaces so that we could come together and really align. And so these are just a few of the partners in Sonoma County that we work with. So a lot of our BIPOC and Latinx serving communities, a lot of our clinics, and we looked at, what can we do? How can we come together to meet the needs? And so now I'll pass it back to you, Susan.
Yeah, so one of the things that emerged during this time for our county was that we decided to form the Coordinated Outreach Collaborative, or as I might abbreviate, COC. And this basically was a collaboration of community-based organizations and community health workers really coming together to support our community during this critical time. It really started out of a weekly COVID vaccine health equity meeting where we were discussing some of the needs in the community and what was already being done. And we really wanted to form this collaborative because we wanted to avoid, we were seeing a lot of siloing of organizations and creating a little bit of competition for funding, that at the end of the day, we all had that same idea of wanting to help our community, and we were seeing a lot of replication. So we really wanted to form this coordinated outreach collaborative to not only stop a little bit of that replication and joining efforts with others, but also to support a lot of those community-based community health workers that were out in the community doing this work, and sometimes with no compensation at all. And so we really wanted to bring this together to be able to provide that. Let me see next. So now looking at the COC structure. So the COC structure was kind of something very unique. Here in California, we, just due to legalities, we are very limited to a $500 stipend. And a lot of the community-based community health workers are undocumented. There's also a lot of these community health workers that we're working with also have low-income housing. So having an extra source of income can really almost be critical for them in terms of losing their housing if they're living in low-income housing sites. So it was important for us to still find a way to properly compensate them during this pandemic work. So we were able to receive funding from Kaiser and the Community Foundation, and they provided this funding to one of the organizations, Latino Service Providers. As well, and Latino Service Providers was able to subcontract with CURA, which is another organization, and us, the Center for Wellbeing, to be able to be kind of just the backbone support for these community-based groups. So we did payment in rotations. We had community health worker ambassadors that basically were experts in the community and had so much experience working with promotora groups. So they would kind of help inform the work that we were doing, the backbone support that we were doing. And then we opened up the rotation. So we wanted this to also be a time for professional development opportunity for community health workers. So with the COC, we made it so that we created a job posting, a job announcement saying, hey, we're looking for community health workers for this project. And all of the promotoras, went to an informational session. They learned about it. They also went through a formal interview process if they are interested. And we also had lead opportunities, meaning that we would identify 3 leads that would kind of help with coordinating a lot of the events and activities and the communication between community health workers. So we opened up those opportunities for them to be able to really again, build that professional development. We signed on all of the promotoras. We just wanted to go through that formal interview process so that they gain those skills. And then we did it in rotation. So each of our organizations was in charge of, bringing all the promotoras were divided into 3 groups, and we were in charge of bringing in each of those groups. So we would work with them for 3 to 4 months, and then we would rotate in another, and we'd work with the next group. And again, after 3 to 4 months, we'd rotate again. And it was our responsibility as an organization to be able to compensate those community health workers with the stipends. So that was part of our model. So again, that would expand the funding opportunities for the community health workers. So next slide. And basically our goals with the COC was just to create a synchronized and trusted network for community outreach. Again, we knew that community health workers were already doing a lot of this work in the community, and we just wanted to be able to provide some support. We also wanted to collaborate among other community-based organizations, again, bringing us out of those silos and really helping us partner to work together, not only as community-based organizations, but also working even with the local health centers to really help serve all of our community. We also wanted the work to be amplified. So the work being done by our community health workers, and it was something that we saw was happening without compensation. So we wanted to amplify that work by providing the trainings, the skill development, the professional development opportunities through this project. And we also wanted to be responsive. So our goal was to respond culturally and linguistically appropriately to meet the needs expressed in the community. And of course, informed by our data that we were collecting in terms of these disasters. We also wanted to engage our community health workers and other key stakeholders every step of the way with the decision process. So what was needed? What do the community health workers need? And we're just there as organizations looking to get those needs filled by providing either the funds for them or purchasing the different supplies that they needed to be able to go out and do the work. And of course, lastly, is just care, to care for each individual doing the work through providing círculos de autosanación, which are just a self-care or self-healing work groups. This was something that we wanted to incorporate as well, because we knew that the community health workers weren't just, providing outreach and information, but they too were being impacted by the pandemic. So we wanted to be able to be there as well for them and provide mental health connections and even a healing circle to really help them through this time as well. Next slide. And so I've mentioned these kind of a little bit already, but there were so many benefits of the promotoras participating in the coordinated outreach collaborative. One, they were able to get so many different learning opportunities. Believe it or not, each organization wasn't just solely focused on providing outreach on COVID, but we were also doing mental health as well as hypertension, which I'll dive into in a little bit. So that was part of them coming in and learning about all these different topics that they could also provide information on, and also something that would help them. We were also had the professional development opportunities where not only were they coming in and doing the interviews and going through a formal job interview process, but we were also offering them computer classes. So here they are at the CHWs Teen Club. This was a space that had computer library. So we were able to go there and we would be able to teach them basic computer skills. We were also able to help them with learning some documentation processes. Social media became something big during the pandemic. So these were all different tools that we were, as organizations providing that structural and support for them, as well as certification. We'll talk a little bit about this, but being able to have that blood pressure certification was another component that we were able to throw in here so that the promotoras were able to walk away with the blood pressure certification. And the most important thing is that compensation. We were able to properly provide compensation based off the amount of work that they were doing, which again, they weren't really receiving a lot of that funding prior. They were doing it because they really wanted to help the community and they knew that this was a need, but it was important that they got the recognition and compensation they deserved through this work too. Next slide. And as I mentioned, through each rotation, they were, with one organization with Cura, they were focusing on mental health. With Latino service providers, it was around COVID. And with us, with the Center for Wellbeing, every time they would, promotoras would enter into our rotation, we'd focus on community blood pressure screenings. One of the things we kept hearing was that folks were at COVID fatigue. They were kind of like, if they would see someone out there tabling outside of a grocery store and they would see that it's information about COVID, they kind of didn't want to hear it anymore. So we kind of had to be innovative, and we're like, well, folks love blood pressure screenings, and this is something that we can easily do. And while we're there, we can ask how, like, here we have some free COVID tests, or here's this information, updated information about COVID. So we were able to have that be an opportunity that we could provide. And again, it's that professional development, because the promotoras had to go through that rigorous training of learning how to do the blood pressure screenings, as well as getting certified by the medical provider to be able to do them in the community. And during this whole, through the 3 rotations, we were able to screen 668 people, and 61% ended up having high blood pressure, which we were able to then help them get connected back to their medical provider, or helping them get established with a health home as well. Next slide. And overall, with the COC, the Coordinated Outreach Collaborative, our community impact was that we were able to reach an estimated 2,000 community members. And the biggest thing is we were able to dismantle a lot of the misinformation that we were seeing or we were hearing about COVID-19, such as the infamous chips with the vaccines. So this was something, again, that Promotores de Salud were trained. We were provided that weekly training support, so that way they would even be stay up to date in the information around COVID, and they were able to share that in the community, as well as that increased knowledge around mental health, hypertension, COVID. That was all knowledge gained for the promotoras and for the community, because we were able to pass that along, as well as create that trust in the community. I think that was critical. Again, one of the things we see from community health worker programs is that we leave behind a sense of trust, to the point that we're asked to come back whenever we have different programming, or if it's the same programming, we're being asked to come back to share that with the community. And so we have that trust built there. Next slide. So yeah, overall, we reached 15,000 individuals. We had 150 COVID events, 5,000 vaccinated, and this was beyond the time of the Coordinated Outreach Collaborative. This was as a whole during the pandemic, with all the different organizations. Next slide. But I do want to still bring it back and highlight the work of the community health workers. Through the COC, the Coordinated Outreach Collaborative, we were able to do an evaluation process throughout the project. And these were some of the key points that the promotoras, or the community health workers, were highlighting that they took away. And that's, they loved having the organizational support, knowing that we were there to support them in, reaching these outreach goals, their professional development goals, that they felt like they were being heard. And there was also a lot of transparency from us as organizations with them about what we could and couldn't do, which was nice to also then have them give input throughout the whole process, as well as the skills training, which I've mentioned with the mental health, hypertension. That was something that they also loved. They also loved the fact that we were always able to provide them with the necessary PPE equipment to be able to be out safely in the community to do the outreach, as well as having sufficient outreach materials, which we know can be costly. And then they also felt empowered. That was the biggest thing that we kept hearing, was they felt like they were listened, they were being heard, they were able to apply a lot of these skills to their own personal lives, and they felt like they were getting all this professional development through this program. Next slide. And just to kind of wrap it up, to this piece is just, here are some of the quotes that we got from the feedback from those community health workers. Someone stated, I always wanted to be a nurse and I never had the financial opportunity. And it was great learning a skill such as blood pressure screenings to be able to learn an aspect of work. So again, those dreams are, that promotoras have, the community health workers have. It's just like, how can we continue to help and support them in achieving those goals that they have? Someone also said, it is never too late to learn, and I appreciate every learning opportunity that I have received through the COC program. Lastly, I like providing the resources and education, being a role model for others in my community. I had an experience sharing with a woman in community where I taught her about clogged arteries and the importance of heart health. And I felt like I really made a difference. And I think that as community health workers, we can always say that when we get that response from community members, it really does feed our soul and, makes us want to continue to do this important and vital work for our community. Excellent. And here's just a lovely photo. This was us at the graduation. We have some of the promotoras as well as some of the organizational staff and some of those community health worker leads as well. There we had a big celebration with food, certificates, music, just to really, and we invited their families too, so we could just celebrate this work that was done.
So thank you so much, Susan. So moving on, one thing that's so important that Susan said is really being culturally responsive and knowing that food and music and celebration and community and family is so essential to the work that we do, and that also helps build resilience for community health worker. We really, despite the pandemic, made sure that we were always centering it in celebration too. So all this work, we really saw that our county was starting to really recognize the amazing work of community health workers. So there was a lot of award ceremonies. Here we have Martine, who was actually former support at the Center for Wellbeing, and then started working for the county and some community health worker funded activities. And so we really see our community keep coming back around celebrating community health workers. And then as part of this, we really wanted to uplift the voices. And Susan can talk to how it is that she was really able to connect to the community health workers and kind of have these listening sessions.
Yeah, so this was also very critical. Like, we had community health workers doing all this amazing outreach in the community, but this was also a time of crisis, right? We had the fires, we've had COVID. So these were emergent crises that were happening within our community. And, the promotoras were always there to respond, but we knew that they had a wealth of knowledge of what worked and what didn't work. And we felt that it was important to host listening sessions to see, during the fires, what worked. Did the messaging work of like getting an announcement that, you need to be evacuated? During the pandemic, did you get the proper information about the vaccines and where you can access the vaccines? So we knew that the promotoras were very, had that intimate knowledge of all of that because they were the ones doing a lot of the outreach for this. So we held listening a few dozen listening sessions where we invited promotoras, and we had food, we had childcare, and we also provided compensation for their time to be able to come and share that with us. So that way we can put this report or this presentation together. So that way we can share back to all of our county partners. So that way we can continue to make improvements.
And so this is really about, again, respecting leadership and uplifting voices, because it's about bringing it back, right? There's so often that there are kind of studies done in community, and where are those gaps? And, people with power take that information and it's never brought back to those community members. And it is so important to bring it back and also say, what are we doing with this information? How are we leveraging this? And so what we did is we were able to go to one of our community foundations. We got some funding, and, with Susan's work with the promotores, we were able to compile this information. We did a lot of, interviews too with key stakeholders. And the point was, nothing for us without us, or don't do anything for me without me. And we brought this information back, and we went all over the community. We went into dozens of different spaces to be able to share this information. And this was really about the relationships. So It's important to acknowledge that the relationships that were built between organizations, groups, and individuals during the pandemic response, and the commitment to uplift, support, share, and collaborate in an effort to promote the recovery and resilience of all in our community. And we really wanted to highlight, like, there were a lot of rich learnings during this time. And as Susan mentioned, not all of them were things that worked well. And so we wanted to be poised to be able to respond in the next time. So some of the challenges were messaging and power dynamics. So we saw when messaging was first coming out from the county, it was predominantly in English or really high literacy, not respecting literacy levels, not necessarily culturally responsive, a lot of dense information, as you can see here. Didn't necessarily reach high impacted neighborhoods, and inherent to some power dynamics, a lot of communities have mistrust of government. And so having a big county signal or logo at the top didn't feel super great for some people, and didn't really reach a lot of folks because of that. So the community came together, and there were so many artists that came out and, were able to be engaged and paid to create really culturally relevant messaging. You can see a number of organizations here in this flyer to the left. Were really coming together to have clinics that were all around music and food and fiestas, and really helping people come out into community. And then we saw our non-profit providers, also our clinic providers, giving more culturally responsive messaging. We also saw that early in the pandemic, a lot of these spaces of power where information was being convened did not have the critical component of community health workers. And a lot of these spaces were in English only. And so there was really kind of a driver of making sure that these spaces were created in Spanish that were responsive to frontline workers and community-based community health workers, and also the nonprofits that served these marginalized communities. And so not just the power holders of the public health officials or CEOs, et cetera, really needed to be boots on the ground for those that were doing this frontline work. We also saw that there were barriers to accessing a lot of the resources. So with the technology divide, a lot of the signing up for COVID tests or vaccines, you had to go through a portal. And if you don't have access to internet or knowledge how to navigate websites or apps, this became a real challenge. And they weren't necessarily user-friendly. They had a high level of literacy, and so those that were lower literacy levels couldn't necessarily navigate it. And that's one of the reasons why, as Susan mentioned, we responded to that. So we did some education around using computers. We even did a laptop lending program to be able to get computers in the hands of people needing it. We also saw that there was other kind of systemic issues, right? So if vaccine booking required emails or social security numbers or medical insurance, this was a huge barrier for folks. There was also other things, so applications that were difficult to navigate, excessive requirements, and just lack of timely response. So we compiled all this information, and again, to bring it to those that held power. And so it wasn't just the pandemic. Here we have a picture from the 2019 Kincaid fire. Again, 40% of our population was evacuated, which was huge. And a lot of the resources that were available were not responsive to the communities that needed these things. So specific needs were not always addressed, resources provided were not always relevant. So certain things like food that wasn't culturally responsive or clothes that weren't culturally responsive. So we really centered on intention versus impact. So this one quote: "During the fires, we were evacuated and told to go to a shelter. I'm an Indigenous person, and when I arrived, there was no one who spoke my language or even Spanish. I was just placed in a corner. I was just placed in a corner. Then when it was time to eat, it was hard for me because it wasn't the type of food of my culture. It was foreign to me. Then when I was asked if I needed clothes, I was handed Western clothing. I get it. Beggars can't be choosers, but this made me feel this really made me feel invisible. And so these were really important stories to bring back to people in power. Again, so that cultural sensitivity, what things are being donated, what resources are available. There was also barriers to access vaccines, so signage, registration, and paperwork, pop-up clinics. When we were working with a lot of our nonprofit providers, just the barriers to be able to get a pop-up clinic, like we needed to get permits, and we needed to, have all of these like coordination with coding and whatnot. So this really prevented a lot of the service providers from being able to meet the need, even if we had the desire and funding to do so. And then there wasn't necessarily a responsiveness to different abilities. So those that are on the spectrum, or even being able to meet those with needs with different learnings. So all of this was to say that we made these recommendations going forward. So really looking at what worked. We always want to bring it back to that strength-based place, right? So really centering on what worked. So creating those spaces about COVID health equity meetings where it's in Spanish and we have translators available, where we're inviting the nonprofits, the community health workers, and then different service providers or information from the county. That this was really a collaborative space. It was community driven, and it was really centered on the work for those that were boots on the ground. This led to a community-led response. We were able to really coalesce around best practices, and this is what gave birth to the Coordinated Outreach Collaborative. And it was really compassion-centered and human-centered, and there was a lot of grace in working together, even though it was very challenging. So this was a critical step of not doing it for me, but doing it with me. That community collaboration was something that really led to this co-creation of culturally responsive messaging, coordinating with our public health providers, artists, and community health workers, our commitment to reach the most impacted communities, so those that had a high level of trepidation or concerned about county or government. And then we were consistently evaluating the messaging. So we were able to pivot and respond and update depending on those needs. And so this collaboration was essential to bridging and building trust among government, clinics, nonprofits, and community health workers and promotores. We also saw that community-driven organizing was really important. So when we created the Coordinated Outreach Collaborative, again, this wasn't top-down. This was really driven by the community health workers. This is really designed by them, and we were just there to support, facilitate, bring resources. So really looking at having the community health workers destigmatize access to vaccines. So as Susan said, really kind of disrupting some of those myths and being able to address it. And one thing that was so cool about the community-based engagement through the blood pressure screens is once we had somebody seated and they were excited about learning about their blood pressure, we're like, and then what's your vaccine status? And then have those conversations, which was just a really great way to like have a nice dialogue with somebody and come with curiosity and compassion. We were able to do a community needs assessment. So figuring out where we're going to have these vaccine pop-ups, figuring out which communities were not being reached and why. And then what were some of the strategies to be able to address that? So door-to-door canvassing, tabling, health fairs, social media, radio, etc. And we also looked, because we're in a pretty big geographic area, kind of leveraging those relationships with other nonprofits, other community-based promotor group, and then having unique strategies across the county. And so this is something that we wanted to uplift in the case that there's another emergency. And so that idea of really meeting community health workers where they're at, sharing this power, providing access, and then distributing resources. Other things were in the methodology. So really responding with compassion and care. So educate and empower. Empower is a word that is sometimes charged, but really recognizing that those that have historic privilege and power their job is really to look at how do we bring that equity, how do we bring that justice into the space, and how are we responding with cultural humility, healing informed care, and then really empowering that leadership in the community health workers, looking at those assets, those innate abilities, so that we can recover and heal. And then responding and resourcing our community. So having that culturally responsive lens and humanizing approach when providing resources. And then also walking the talk. So again, really helping those people in positions of power, understanding what the burden of their responsibility is, right? So holding that awareness of generational and historic trauma in our communities, understanding the harm of our past actions, and then responding and repairing by transforming disaster response systems to be trauma and culturally responsive. So we're going quickly through this because we want to make sure that we're on time. But the whole point of this is that through the work that Susan did and the promotores, we were really able to elevate the voices and demand respect for the leadership of community health workers. And so by 2023, COVID was a distant memory for a lot of people. And we kept celebrating this and uplifting these stories. At our celebration of Dream event, our promotores came and shared with people that had positions of power at this event how important their work was and really celebrated. But as of February 28th in 2023, the Sonoma County lifted COVID-19 emergency health orders. And then our emergency funding termed, and we couldn't continue this outreach. But there's still a need. So this is from today. So under 24% of Sonoma County population is up to date on their COVID vaccines. And we're seeing that the numbers are rising, and not just with COVID, but RSV, norovirus, the flu. So we're seeing that we're having a continued need in our community. And again, our most marginalized populations are disproportionately impacted. So what did we do? We centered on community health worker advocacy. So we worked to put a proposal together, and we wanted to say, you know, this need continues. We haven't been able to get grants. The emergency is now considered a distant memory, but we want to make sure that we're getting vaccines to those that need them. So we wrote letters, we called our elected officials, we really engaged our community health workers, because advocacy is one of the core skills and competencies of a community health worker. And so we went to our Board of Supervisors, and these are pictures from the day that we were allowed to go and speak. And so we have some of there was a long line. I've gone to the Board of Supervisors many, many times, but it was very intimidating. There were so many people and it was a long line. And so we waited in that line for hours, and we went up and we gave our 2-minute speech. And we had so many promotores that came, and they had rehearsed and practiced, and it was super powerful. So here is Noemi, one of our amazing community health workers. She is the president of Roseland CBI and Equidad. And here she is talking to the Board of Supervisors with their translation headphones on. And guess what? It was approved. And so their leadership was respected, their voices were heard, and we are able to go out and meet the needs of the community. So why is our story important? Telling this story is important because we need to honor the many individuals who led this transformation by elevating their feedback, the lessons learned, and recommendations to those who hold power to make systemic changes in future emergency response. So nothing for me without me. And I'll leave with this quote: never doubt that a small group of people, of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. From Margaret Mead. So thank you so much for joining us today. This is our information if you have any questions for us. And yeah. Let us know if there's any questions. Thank you, Paige. Nice to see you, Paige. So one of our participants, Paige, actually did a whole study with the County of Sonoma to create a framework for community health workers in Sonoma County. Thank you, Laura. Any last words, Susan?
Just thank you, everyone. I was seeing some of the sweet comments in there about just, you know, our work and that it's beautiful. Congratulations. And just thank you, everyone. And I see that it sparked some hope in some, and others have kind of like similar projects going on. So it sounds really incredible to just, again, see how this is not just here in Sonoma County, but that other places throughout our whole state is, you know, working with this incredible model that is community health workers.
Yes, our goal is to radically transform the landscape so that all of our humans can live happy, healthy, and thriving lives. And it is my firm belief that community health workers have the power to do that.
Right.
All right. Well, thank you, everyone.
Bye.
Yes, vaccination season is coming. We're going to get out there.
Right.
Thank you.
I think we could hop off too.
Yeah.